Hello everyone, this is Dr. Singaram. In this video, I will be discussing recent pattern FMGE questions as well as some potential questions which can be asked in the coming exams. I have divided the sections in pediatrics into three: neonatology, general pediatrics and systemic pediatrics. So today I will be discussing the neonatology part. Very soon I will be uploading the videos regarding the discussion on general pediatrics and systemic pediatrics. Let us get started with the first question. This is a very important question regarding temperature regulation in a newborn. The question is most common site of radiation heat loss in a neonate. Before I start discussing the question, when we talk about heat loss in a neonate, there are different ways by which a baby can lose heat. One of course is radiation. What are the other ways in which a baby is going to lose heat? This includes evaporation. What are the others? Next one is the conduction, and the next one is the convection. Out of these, if we see, the most common type of heat loss or the most common source of heat loss in a newborn is radiation. Most common source of heat loss in a newborn is radiation, and that by itself is a separate MCQ. Now coming to the question, they are asking about the site of radiation heat loss in a newborn. You have the option extremities, head, axilla and trunk. What is the answer? The answer for this question is head. Why do you think in the entire body head is supposed to be the site of maximum heat loss? Why? Because when we look at the surface area, head has got the highest surface area in the body. The surface area is the highest in the head region, so that is why radiation heat loss is also occurring commonly from the head region. Are you able to follow this? Some of you might mistake with this option, which is axilla. Please remember, axilla is not the site of heat loss. Instead, axilla is the site of temperature measurement in a newborn. Please remember this point. If they ask you the question, what is the preferred site of temperature measurement in a newborn? Then the answer is axilla. One more question which is possible here and has been asked previously in your exams is, what is the minimum duration of temperature recording while you keep the thermometer in the axilla? The answer should be minimum of 3 minutes. Very important. If you don't keep it for 3 minutes, you are going to get a wrong value. That's also equally important and should be noted. Let us look at some more one-liners. What is the normal body temperature in a newborn? It is 36.5 to 37.5 degree centigrade. Please make a note of it, 36.5 to 37.5 degrees centigrade. Now, what is the recommended delivery room temperature? The books may vary, but according to our standard books, it is 25 degree centigrade. It is 25 degree centigrade. That is a recommended delivery room temperature. Don't get confused with the body temperature, which is always higher than the ambient temperature. Next, what is the best way to maintain temperature while transport of a high-risk newborn? High-risk newborn transport may be something like a preterm baby or a baby having some important medical complications who needs to be transferred from a peripheral center to a higher center like hospitals. Okay, then the question is, what is the best way to maintain the temperature during the transport of these babies? Okay, please remember the answer for this particular question is something called as transport incubators. Something called as transport incubators. Please remember, some of the students wrongly answer as KMC or Kangaroo mother care. That is absolutely wrong. It is always transport incubators which are best for maintaining temperature during transport of newborns. Let's move on to the next question. Very important question on Kangaroo mother care, which is abbreviated as KMC. All of the following are true except, that means they are asking about which is the wrong statement about Kangaroo mother care. Skin to skin contact with the baby and mother, that is a correct statement. KMC means putting the baby skin to skin contact with the mother. Next, exclusive breastfeeding. Yes, exclusive breastfeeding is always recommended whenever we feed a newborn baby. That's also correct. Initiated in a facility and continued at home. Yes, generally the Kangaroo mother care is indicated for low birth weight babies. Remember, it is for stable low birth weight babies. That means babies who are weighing less than 2.5 kg. Usually it includes a group of preterm babies which are usually low birth weight. Okay, so what happens is that when the baby is stable, we keep the baby in contact with the mother, that's what we call it as kangaroo mother care, and it is initiated ideally in the hospital itself, and it is continued at home. Okay, till when you need to continue, it is continued till the baby is attaining the normal weight of 2.5 kg, or once the baby has attained 37 weeks of gestation. Till the time you have to continue kangaroo mother care. Now look at the last option. Each session should be ideally 30 minutes or less. This is a wrong option and hence the answer for this particular question, because remember, once the kangaroo mother care is started, each session should be more than like 1 hour, 2 hour, 3 hours, 4 hours, like that. It should never be less than 30 minutes. Why I am saying so? This is because frequently you are handling the baby, that can actually cause stress to the baby. So that is why shorter sessions under kangaroo mother care are never recommended. It should be longer sessions. Okay, right. Ideally we say that once the baby is put in contact with the mother continuously, it should be for at least 4 hours. Okay, right. So definitely sessions less than 30 minutes is never recommended once the baby is under KMC. Hence the answer for this question is option D. This question about which is not a normal observation in a newborn. Remember this, there are many observations which can be in a newborn which can be mistaken for an abnormality, and it is our responsibility to decide which is normal and which is not, and this question is about the same. Which is not a normal observation in a newborn? Okay, let us look at the first option, erythema toxicum. The name toxicum may suggest that there is some abnormality or toxic or sick. There is nothing toxic in it. It is actually a normal finding in a newborn. That is why this word erythema toxicum is considered as a misnomer, because it's a normal finding in a newborn but wrongly named as erythema toxicum. And please remember, erythema toxicum is nothing but, erythema means redness. It is nothing but a maculopapular or papular pustular lesions which are noted in a newborn baby, or very simply you can remember it is a rash noted in the newborn. And the MCQ question is, it is the most common rash noted in a newborn baby. Please remember, because it's a normal finding, there is no need for any treatment. Similarly, the next option, Mongolian spots, is also a normal finding in a newborn. What are Mongolian spots? Mongolian spots are nothing but something like a greenish black or a greenish blue who macules noted in the backside of the baby. It is very common in the Asian and Indian population. Again, doesn't require any treatment. Now look at the third option, breast or engorgement. This is also a normal finding in a newborn. And what is the reason for this breast engorgement noted in a newborn? It is due to transfer of maternal estrogens from the mother to the baby around the time of birth. And this estrogens can stay in the baby's body, say for few days, and during this time it can mediate breast engorgement. What are the other problems which are encountered due to this maternal estrogen? Yes, the baby can have a white discharge per vaginum. That is absolutely normal, and it is due to the effect of maternal estrogen. Once the maternal estrogen effect goes off, what happens? The endometrium starts shedding and the baby can even present with bleeding per vaginum. Please remember, it is due to the effect of maternal estrogen being gone after a few days. Okay, so bleeding per vaginum is also a normal finding in a newborn, doesn't require any other treatment. Now look at the fourth option, blood in the stools. Blood in the stools is never normal. What is the meaning of blood in the stools? Blood in the stools signify a gastrointestinal bleed which is never normal in a newborn. Okay, and one of the very important condition which should be considered whenever there is a bleeding manifestation, especially gastrointestinal bleeds, is vitamin K deficiency. That is why to prevent this, we actually give vitamin K to the newborn babies at the time of birth. We give it as a injection, intramuscular injection into the anterolateral aspect of the thigh at the time of birth itself. Now, what is this vitamin K deficiency bleeding called as? Vitamin K deficiency bleeding is called as hemorrhagic disease of newborn. This is a very important term for you to remember, because in one of your exam questions it has been asked, which of the following is given in the prevention or prophylaxis of hemorrhagic disease of newborn? Answer is vitamin K. This is a previous exam question. Let's look at the next question, which is about neonatal resuscitation. Neonatal resuscitation is always a very potential topic in any competitive exams, and in FMG exams also it is frequently asked. Let's see this question. A term baby at birth did not cry and was given bag and mask ventilation. After 30 seconds, that means after 30 seconds of starting bag and mask ventilation, heart rate was 130 per minute. What should be done next? Okay, whether you have to stop or continue bag and mask ventilation, whether you have to go for intubation or start chest compression. Before I tell you the answer, let me very quickly tell you about outline of neonatal resuscitation for a better understanding. When a baby is not crying at birth, you are going to start neonatal resuscitation. What you are going to do initially is what we refer to as the initial steps of neonatal resuscitation. The initial steps of neonatal resuscitation include drying the baby, suction the secretions from the suctioning the secretions from the mouth and the nose, suction the secretions from the mouth and the nose, put the baby under warmer, which comes under temperature regulation, put the baby under warmer, then gently stimulate the baby by flicking the soles or rubbing the back. This is called as tactile stimulation. These are the initial steps. These are the things which you are supposed to do when the baby is not crying. They are called as the initial steps. After the initial steps, most of the baby usually they cry. However, unfortunately, even after the initial steps, the baby is not crying, then you have to go for the next steps. The next step would include positive pressure ventilation. Please remember a very important question they can ask you. What is the indication for positive pressure ventilation? Of course, not crying after the initial steps. And the second important indication to be remembered is heart rate less than 100. That's an indication for positive pressure ventilation. Please remember the normal heart rate in a newborn is 120 to 160 per minute. So heart rate less than 100 is an indicator actually of hypoxia in a newborn. So you have to start positive pressure ventilation. You know how to give positive pressure ventilation. It can be either by bag and mask, which I am abbreviating as BMV, or it can be by endotracheal intubation. Generally remember, we start with a bag and mask ventilation. If there is no response, then we may have to consider the possibility of endotracheal intubation and ventilation. Okay, right. Generally, bag and mask is the initial one. Right. Now, after you start positive pressure ventilation, you always assess the heart rate as a response. Remember, which will be a good response? Heart rate less than 100 is an indication for positive pressure ventilation. So, if the heart rate goes to more than 100, it means the baby is responding to positive pressure ventilation. Okay, then you can discontinue positive pressure ventilation at that time. However, even after starting bag and mask ventilation or endotracheal intubation, if the heart rate persistently remains low, and if it is low to less than 60 per minute, then you have to start chest compression. Very important. Heart rate less than 60 is an indication for chest compression. And even after starting chest compression, there is no response, still the heart rate is less than 60 only, then you have to consider injection of adrenaline via the intravenous route. Remember, in a newborn baby, you have got a ready-made access to the intravenous route via the umbilical vein. So always remember this point. Adrenaline is given via the umbilical vein in a newborn baby. Okay, right. So this sums up the steps of neonatal resuscitation which you need to know for your exams. Going back to the question says that the baby did not cry and was given bag and mask ventilation. Okay, already started on bag and mask ventilation. You can see the response after the bag and mask ventilation. What is the response? The heart rate has increased to 130 per minute. That means what? The heart rate has increased to more than 100. That means what? The baby is responding to bag and mask ventilation. So what will be the automatic answer at this time? You have to stop bag and mask ventilation because the baby has already responded. If it was less than 130 per minute, then only you have to continue the bag and mask ventilation, or you may have to think of the possibility of intubation also. Okay, but here the baby has already responded, so there is no more need for positive pressure ventilation. Stop bag and mask ventilation is the answer. Few more one liners I want you to remember for your exams. Which is the absolute contraindication for bag and mask ventilation? Answer is going to be CDH or it is also called as congenital diaphragmatic hernia. It's also called as congenital diaphragmatic hernia. Right. Why? Because in congenital diaphragmatic hernia, the intestines are already entering into the thoracic cavity, compressing the lungs. If you give bag and mask ventilation, the oxygen will not only enter into the lungs, it will also enter into the intestine, causing further distension. When the intestines distend, they are going to cause further compression of the lungs and going to cause a bigger problem. So that is why in bag and mask ventilation is contraindicated in case of congenital diaphragmatic hernia. Right. So what is the technique of chest compression? Usually in newborn babies, what is recommended is two fingers. Okay, you can either use your middle and index finger, or you can use your two thumb. But which technique is preferred is the question. It is always the two thumb technique which is usually preferred. Please make a note of it. Two thumb technique is usually preferred. Now, one more very important question which has been asked previously also. What is the ratio of ventilation compression ratio in a newborn? Always remember, whenever we start chest compression, we combine it along with the ventilation. The question is, what is the compression ventilation ratio in a neonate? Answer is going to be 3:1. Please remember, in older children, the ratio is 30:2 if there is only one person available for resuscitation, or if two persons are available for resuscitation, it is 15:2. In adults, what is the ratio? The standard ratio of compression ventilation, it is always 30:2. So depending on what is asked in the question, answer accordingly. In neonates, it is always 3:1. Don't forget it, a previous exam question. Let's look at the next question. Which of the following is not included in the neonatal sepsis screening? Okay, is screening is a set of investigation done to look for the probability of neonatal sepsis. Of course, before I discuss this question, let me tell this straight away. If they ask you which is the gold standard investigation for diagnosis of neonatal sepsis, your answer is going to be blood culture without any doubt. This particular question is asking about screening program in or screening in neonatal sepsis. Okay, look at the first option. WBC count is included in the neonatal sepsis screening. Please remember, in WBC count, usually we are expecting low counts, less than 5,000 per cubic millimeter in neonatal sepsis. Whereas when you look at the older children or adults, we are actually looking at increase in the WBC count, but in neonatal sepsis, it is decrease in WBC count or leukopenia. CRP, what is CRP? CRP is a C-reactive protein that's also included and will be elevated in case of neonatal sepsis. Third option is absolute eosinophil count. This is the wrong option because we are not looking at absolute eosinophil count. Instead, we are looking at absolute neutrophil count, which is also going to be decreased in case of neonatal sepsis. It is less than 1800 per cubic millimeter. You need not remember the numbers, it's not important for your exams. But remember, it is an absolute neutrophil count and not absolute eosinophil count, and hence the answer is option C for this particular question. We are also including micro ESR, which will be elevated in case of neonatal sepsis. So these are the components of neonatal sepsis screen which you need to know for your exams. One more important component of the neonatal sepsis screen is something called as immature to total neutrophil ratio. Immature to total neutrophil ratio, which is going to be increased. So what is this? See, when we look at the peripheral smear and you look for the neutrophils, we will see that there is more number of immature neutrophils than normal. That's all. It is very simple, no? Think like this. There is a infection in the baby. The first line of infection in the baby would be neutrophils. But here you can see that the WBC count is less, or in other words, the neutrophils is also less. So what does the bone marrow do? The bone marrow is under pressure to release a lot of neutrophils. So what happens? The bone marrow starts releasing immature forms of neutrophils into the circulation, and that is what we see in the peripheral smear. Increase in immature neutrophils, or we express in the form of immature to total neutrophil ratio. Okay, and that is also one more component of neonatal sepsis screen which you need to know about. Now, one question which came in your exam was, in neonatal sepsis, which is an acute phase reactant Answer is C, reactive protein. That's also your previous exam question. Let us look at some more one-liners. A very important question often asked in your exam. What is the most common cause of neonatal sepsis? Please answer as Klebsiella. This is for Indian scenario, and if nothing is mentioned, please answer as Indian scenario only. If they ask you the question worldwide, which is the most common cause of sepsis, then you have to answer as group B, streptococcus. Remember, in India, or if nothing is mentioned in the question, answer as Klebsiella. Only worldwide is mentioned in the question, then answer as group B, streptococcus. Right. Now, what is the cutoff time to differentiate early from late onset sepsis? Remember, less than 72 hours from birth, if there is infection, it is called as early. After 72 hours, it is called as late onset sepsis. Basically, remember, in early onset sepsis, the infection should have been acquired from the maternal tract or maternal genitalia. Okay, so the source of infection in early onset sepsis is maternal, whereas in late onset sepsis, it is acquired probably from outside. What is that outside? It means the hospital. That's called as nosocomial infection. So, most likely late onset sepsis is something which is acquired from the hospital setup or nosocomial infections. Right. Now, one more question. Empirical antibiotic for neonatal sepsis. Remember, when we talk about empirical antibiotic, we need to give a spectrum which will cover both gram positive as well as gram negative organism. You can very easily infer, no? Klebsiella is a gram negative organism, whereas group B streptococcus is gram positive organism. So you need to give a coverage for both. So that is why empirical antibiotic is usually a penicillin for gram positive spectrum, which is usually ampicillin. Along with that, you give an aminoglycoside, typically like a gentamicin or a amikacin. So it is a combination of penicillin plus aminoglycoside, which is the empirical antibiotic of choice for neonatal sepsis. Next is questions on neonatal jaundice, which is again a very important topic for your exams. What should be the minimum level of bilirubin to cause jaundice in the newborn? Remember, the question is about minimum level of bilirubin. Okay, right. That means above what level you can see jaundice or visible jaundice in a newborn. Right. Answer for this question, it's a straight one-liner. Please remember as 5 milligram per deciliter. Anything which is 5 or more than that is going to cause visible jaundice in a newborn. Right. Now, if the same question was asked, which is the minimum level of bilirubin for visible jaundice in an adult or a older children, then please remember in adults or older children, it should be more than 2 milligrams per deciliter. Are you able to follow this? So, depending on the question you have to answer. Newborn, it is 5 milligram minimum. Other age groups, it is 2 milligram per deciliter. Now, if they ask you which above what level it is actually dangerous, please remember bilirubin levels of more than 15 milligram per deciliter is dangerous jaundice in a newborn, and this is reflected by involvement of the palms and soles. So when you look at the baby, if the palms and soles are affected, it is likely that the jaundice is more than 15 milligram per deciliter. It is considered as dangerous because when we talk about this jaundice, more commonly what type of bilirubin increases? It is an indirect bilirubin which increases commonly. There is also conditions, pathological condition where conjugated bilirubin increases, but generally it is an increase in the unconjugated bilirubin we are talking about. So basically, if there is too much of unconjugated bilirubin, what is the problem? If there is too much of unconjugated bilirubin, the problem is that this will cross the blood brain barrier and will get deposited in the basal ganglia of the brain, a condition which is referred to as kernicterus. A condition referred to as kernicterus. So that is why we always say that whenever palms and soles of a baby is jaundice, immediately measure the bilirubin level and start treatment in the form of phototherapy or exchange transfusion as the need is. Okay, right. So please remember, dangerous jaundice means bilirubin which is exceeding 15 milligram per deciliter. That should be remembered. Why this topic of jaundice is very important? Because jaundice can be both normal or physiological as well as pathological or abnormal. Our role is to differentiate between these two varieties. Right. Now, as a general term, remember some points about this physiological and pathological jaundice. First up is the physiological jaundice, which is obviously more common compared to pathological jaundice. Physiological jaundice is always increase in unconjugated fraction of bilirubin. Always increase in unconjugated fraction of bilirubin. And please remember, physiological jaundice never appears on day 1 of life. Never appears on day 1 of life. Are able to follow this? These 2 points should be remembered for physiological jaundice. What about pathological jaundice? Pathological jaundice can be either an increase in unconjugated bilirubin or an increase in conjugated bilirubin. Out of these two, you can just remember that whenever there is an increase conjugated bilirubin, it is always going to be pathological. Why? Because I said unconjugated bilirubin increase can be either pathological or physiological, but conjugated bilirubin increase is always pathological. Are able to follow? It is always pathological. That point should be remembered. Now, our only confusion is going to be whether it's a uh, in case of an unconjugated bilirubin increase, whether it's a physiological or pathological, and that is what the points we were discussing. What are the points for pathological unconjugated bilirubin increase? Number one, it can appear on day 1. It can appear on day 1 of life itself. So any jaundice appearing on day 1 of life is pathological. Second point to be remembered is that it can extend beyond 14 days, because in normal babies usually the jaundice lasts only up to a maximum of 14 days, but in pathological jaundice it extends beyond 14 days. Able to follow? Then the third point to be remembered is that pathological jaundice can involve the danger zone. What is the danger zone? Yes, it can involve the palms and soles. Whenever you are seeing a baby with involvement of the palms and soles or yellowishness of the palms and soles, immediately think it may be a case of pathological jaundice. Act fast and start the treatment. So coming to the final question in the newborn section, a baby is born to hepatitis B positive mother should receive which of the following? Hepatitis B vaccine or hepatitis B immunoglobulin, or both vaccine and immunoglobulin, or there is no need of prophylaxis. First of all, remember, a baby born to hepatitis B positive mother requires some form of protection. Definitely requires prophylaxis. Why? Because without prophylaxis, please note that there is an increased risk of infection, obviously, but what is more important is that there is also an increased risk of chronic infection. Please remember this point, increased risk of chronic infection with hepatitis B. What is this? Remember, if an healthy adult is going to acquire hepatitis B infection, say via the blood transfusion, what happens? Most of the time, they don't develop a chronicity. Okay, they don't develop a chronicity because our body's immune response itself helps to overcome that hepatitis B infection. However, when a newborn baby is acquiring a hepatitis B infection from the mother, the baby's immune system is basically weak. So what happened? This predisposes the baby to develop an increased risk of chronic infection. Remember, the risk of chronic infection without prophylaxis is to the tune of 90%. This is very high number. Okay, so that is why always remember, a baby born to hepatitis B positive mother should receive prophylaxis. And what is the prophylaxis they need to receive? They need to receive both hepatitis B vaccine as well as immunoglobulin. Very important point. At the earliest you have to give her, or as early as possible you have to give this. The guidelines say that within 12 hours both hepatitis B vaccine as well as immunoglobulin have to be administered to the baby. This basically decreases the risk of infection as well as decreases the risk of chronicity of infection. So that concludes this discussion. Thanks for watching. Very soon I will be uploading the question discussion in general pediatrics as well as systemic pediatrics. Please subscribe to this channel to get notified of new videos as and when they are posted to this channel. If you have any questions, please put it up in the comment section below. I will be happy to answer them. Thank you and have a good day.